Well, how many times in the past year have you heard the term mental illness used to describe the condition of someone in the news, a friend, a colleague, even a family member? Probably a lot more than just a few times. But how often do you actually talk about it? Well, tonight we will, because it's important. Our National Checkup panel is here to help. Danielle Martin is a family physician at Women's College Hospital here in Toronto. Samir Sinha is a geriatrician at Mount Sinai Hospital. Viv Rao is division head of cardiac surgery at the Peter Munk Centre. And Leslie Weisenfeld is the deputy chief of psychiatry at Mount Sinai. Their thoughts in a moment, but first, some hard facts. Here is a staggering figure. In any given week, at least 500,000 Canadians are unable to work due to mental health issues. Think about that, 500,000. That actually costs the country more than $50 billion a year in healthcare expenses, lost productivity, and reduced quality of life. Who are these people? Well, you don't have to look far. 1 in 5 Canadians will experience mental illness in their lifetime. It affects people of all ages, all income levels, all cultures. 8% of adults will experience major depression at some point in their life. Suicide accounts for 24% of all deaths among 15 to 24-year-olds, 16% among 25 to 44-year-olds. There are lots more statistics we could use, but enough with the numbers. Time for some thoughts about why this is happening, why we have so much trouble talking about it, and what can be done to make things better. And let's start on that talking issue. Why does there still seem to be a stigma around mental illness? Danielle?
Well, I think because the causes of mental illness are not easily directly observable, the way you can see a broken leg or a tumor, that family members and friends and the general public of people with mental illness often can have the misperception that it's just a matter of kind of getting over it and moving on, and they can't understand why it is that it is so difficult. And so I think that is a major contributing cause. Now that we're understanding more and more about brain chemistry and starting to understand that neuroscientifically what happens to the brain in mental illness, I think that we're starting to get over some of that stigma.
Leslie, how do we, let's try and break this down with some basics here. How do we help somebody who's going through depression?
Well, I mean, probably the most important thing to start with is to make sure people who are suffering from depression first see their family doctor and realize that they should go to see their family doctor with a concern about their mood, the same as they would go with any other problem, because often that's the most important step they can make to make sure they get access to treatment and that they get the kind of treatment that they need, both physically and mentally. And then once they do that, it depends on the nature of their depression, how severe it is. But I think the critical step is to realize there are good treatments that work for depression, the same as for any number of other medical illnesses.
All right, we'll try and get into some of those treatments in a moment. But staying on the basic grounds, Viv, what would you say?
As Danielle said, we've never really recognized it because it was hard to predict who would develop mental illness. We have traditional risk factors for a lot of diseases that we deal with day to day. We don't have a lot of traditional risk factors for mental illness. And a lot of times, people who think they may have a mental illness are afraid to speak out and afraid to seek help. And I think our job as physicians is to allay that fear and to say, if you think you have a mental illness, speak out about it, because it's important that you get treatment. There is treatment that is effective.
Well, before you can speak out about it, you've got to know that, in fact, you may have a problem. So how do you know that?
Well, I think the way we approach, mental illness and its diagnosis, or just awareness, is that, if you're having, feelings that are, if we're talking about depression, if you're having feelings of sadness or mood issues that are just not the usual ones that you've had, for example, if you're having trouble concentrating, if you're having trouble sleeping, if your patterns of thinking and just the way you feel aren't normal, then you may actually have a mood issue, for example. There may be something going on, and there's sometimes physical symptoms that might be associated with it. So generally, it's just being aware, and if you feel different, and those are sometimes the opportunities to seek help with your family doctor and investigate if this is an issue.
What's the biggest misconception that we have about mental illness, Leslie?
There's so many, but I think one of the biggest ones is that you should just be able to overcome it by yourself, that you should be able, if you just tried harder, if you just kind of concentrated more on getting better, you could just get better on your own. And although many people can contribute to their own care in a really thoughtful way by engaging in care. When people are really seriously depressed or anxious, they often need some combination of treatment plus their own participation in order to recover fully.
Do you want to add to that, Danielle?
Yeah, I mean, the thing that I worry about is the misperception amongst the public that people who are mentally ill are violent. And I think we've actually seen some of that even in recent media coverage, for example, around lone terrorists and rates of mental illness. There's a fear among the public that people who have major mental illness are a risk to the general public, and that's not borne out by the statistics. In fact, people who are mentally ill are much more likely to harm themselves than harm others. The rates of suicide are much, much higher, as we saw in the statistics tonight, than the rates of homicide. So I think that we need to help the general public to understand that a person who's mentally ill is not a risk to you as a member of the public, but it is a person who needs help and deserves our collective effort.
All right, well, let's talk about some of that help, because this is where there are, as Leslie said, a number of different ways you can go on treatment. Talk to me about barriers, first of all, to treatment. What are the biggest barriers that we see there to getting treatment in this country right now?
Well, I'm going to go back to the misconception point.
Okay.
And the first thing is people think it'll never happen to me. It can't happen to me. I'm a high-functioning individual in a career. And I can tell you, the recent study came out of University of Toronto looking at surgeons, who probably are the biggest type A's that you know out there. And there's a significant prevalence of depression in surgeons in their mid-careers. So recognizing that could happen to you is probably the first barrier to say, okay, let's deal with this and let's admit the fact that I may have a problem, and then seeking help. And I think, as Leslie said, approaching your family doctor is your first line to say, I think I might have an issue, and here's what I'm concerned about, and start to speak about the issues.
Well, that's where, from what I've read, some of the concerns exist, because you do the family doctor thing, and then it's that next step. It's getting past the wait lines to see a psychiatrist or a specialist or whatever. Is that a major problem?
I think it can be a big problem, and it's a problem in many cities and across the country. I think the other barrier sometimes, is that people may find, in even speaking with a very kind of capable family physician, that between them they're not quite sure, what would be the best treatment and whether or not they need psychiatric help or they need medication or they need talk therapy. And I think another key barrier is people may feel if medication is quite properly recommended by their family doctor, some people may feel that itself is a bit of a failure, that they should be able to recover with some other kind of treatment. So that's another barrier that happens a lot, I think, in conversations with patients and their physicians.
All right, talk to me then about the options on treatment. Samir, why don't you start us? Obviously, going to a psychiatrist, a specialist of some sort is one area, but there are also, treatments you can take, like physically take.
Yeah, I mean, there's a variety of options available. I think some people actually can do well with just some counseling and support, and not necessarily even just from a family doctor or from a psychiatrist, but there are other mental health clinicians out there. So there are psychotherapists and other counselors that are available. Other people may need the additional help of a medication, and one thing that we try and emphasize to our patients is that if you need the help of medication, it's not that you failed other options. Sometimes people need that extra support to help manage their depression. So there are various medications depending on the type of mental illness that one might have, such as antidepressants or other medications that can be quite helpful. And then there are other therapies as well, such as cognitive behavioral therapy. There's mindfulness treatments, and there's a variety of options out there. And so I think depending on how complex a person's case is, it may be something that they can deal very well with their family doctor. But this is where I rely on my colleagues like Leslie and others, especially for more complex cases, because sometimes people need a variety of treatments as well.
Don't forget the therapeutic procedures, and you mentioned ECT previously, and that has been used successfully. There's research into deep brain stimulation with implantable devices and implantable depot drugs. So there's a wide spectrum of treatment options for people with mental illness, and we're just scratching the surface, I think.
How hard is it for the family physician at this point, Danielle? Is it a pass-off at a certain point for you?
Well, the thing about family medicine is it's never a pass-off, in the sense that people always do better, no matter what their medical condition, when they maintain that close connection with their primary care provider throughout their treatment. What we're good at in family medicine is, first of all, identifying and helping to diagnose that there's a problem, helping people to manage that kind of intersection between what you can do for yourself behaviorally. So we know, for example, that exercise is a very important part of the treatment for almost every form of mental illness, as well as connecting people with the right kind of talk therapy. We're very good at managing the first-line medication treatments for virtually every kind of mental illness, and then helping the patient to navigate the system to figure out what's the right resource given the circumstance that you find yourself in. Is it finding you a social worker? Is it connecting you with a mindfulness meditation group? Is it getting a psychiatrist to give you a specialist opinion? So trying to figure out what the right kind of strategy is at any given point in time, and then helping to follow the response to treatment over time, because what you need today might not be what you need next week or the week after. So maintaining that tight connection is always really important.
Viv, help me with one specific area, and that is people going through a life-changing experience who are suffering depression as a result of it. And I'm thinking heart surgery. How do you deal with that?
It's very difficult to deal with it. And unfortunately, from my perspective, we don't really see it in the acute hospital setting. It's several weeks later after they've gone home and the event has sunk in. And there's a study that we did several years ago looking at the prevalence of depression after open heart surgery. And in various subgroups, it's as high as 20%. And surprisingly, it's higher in the younger patients than it is in the elderly. And that's another misconception out there, that mental illness tends to affect the elderly. In our study, it was more prevalent in the younger patients, and it sort of makes sense. You think you're invincible and you're healthy, and all of a sudden you're under the table and you're having open heart surgery. You know, for the first few days, you're just thankful that you're alive and that you've survived this intervention, and then the magnitude of it sets in, and the depression sets in that I'm not immortal and I have a finite lifespan. So you know, it affects us, and one of the things that we've recognized is that it is a problem. It leads to prolonged hospital stays when people aren't, active after their surgery. We've dedicated a full-time psychiatrist to this. So I think we're one of the unique programs in Canada. In our cardiac and vascular surgery divisions, we have a full-time psychiatrist who looks after, screens our patients to see if they're at risk for post-operative illness, and treats it actively when it's identified.
All right, Samir, I want to get your thoughts on the same question, but in specific in terms of simply aging and how you deal with that. But we've got to take a break. So time for that quick break. But when we come back, also this question: do we have enough resources to deal with mental illness in Canada? And welcome back to our National Checkup. Tonight's topic, mental illness. At the table, Doctors Danielle Martin, Samir Sinha, Viv Rao, and Leslie Weisenfeld. Let's pick up where we left off quickly with Samir. The depression of aging. How do you deal with that?
Well, I think, there's often misconceptions that as we age, we may encounter more mental illness, but actually rates of depression amongst the elderly are actually pretty similar to the rest of the population. So I think that's one misconception. But I think it becomes a little bit more complicated because, people may encounter more losses of loved ones, for example, more life-changing events, such as moving into a nursing home. And I think we have to be mindful that those could be events that could be associated with depression. And the only other consideration is that we have higher rates of dementia in older people, and sometimes dementias can trigger depression. Sometimes the symptoms can seem similar, and so it can be confusing, and sometimes people can have both. So that's why I think if you're having any changes in how you're feeling, or you're noticing changes in people's thinking and memory and maybe mood as well, this is a really good point to start with your family doctor, and you may need to get the help of a geriatrician or a geriatric psychiatrist.
Last question, and it's this issue of whether or not we are well-resourced enough in Canada to deal with the issue of mental illness. Leslie, what's your feeling on that?
Well, I think when you look at the burden of mental illness in terms of the amount of suffering and also the amount of disability that's really caused by mental illness, that we're probably not resourced enough in terms of dealing with mental illness. And we're also probably not organized well enough to make sure that people can access, as Danielle said, the sort of system navigation, trying to figure out how to get help when you even have the sense that you have a problem is probably one of the biggest challenges people face. And no wonder when there's not kind of one kind of organizing way that people can figure out how to get help when they need it. So not enough resource and not enough organization.
Danielle?
Yeah, I think another one of the barriers is that in most provinces, while physician care is covered in our provincial health plans, most non-physician mental health providers are not, whether it's a psychologist or a social worker or whatever. So people who don't have private insurance to pay for those services are often waiting to see a psychiatrist, not because that's necessarily the most appropriate provider for them, but it's because it's the one that's publicly covered. And so we're probably not doing a good enough job of organizing the resources that we've got. And where there are bottlenecks, it's sometimes because we've sort of heavy end loaded our physician supports and not thought deeply enough about the other supports that people might need.
All right, good thoughts. Oh, Viv will owe you one for the next time around because we're out of time on this one tonight. But thank you all. Great discussion.